It's important, like everything else, it's important to know the basic anatomy and structure of the eye, right? Like all of neuro, form follows function, right? So when you're talking about the portion of fluid in front of the iris, it's referred to as the anterior body or the aqueous fluid. And when you're talking about like the actual like inside of the eye, it's the vitreous body or the vitreous fluid. The only reason I point that out is because sometimes they like to flip back and forth between these terms and questions. And there's no need to get a question wrong just because you're confusing the terminology they're using. The other thing that's important is the iris is responsible for the size of the pupil, which, right? So how much light is let in, and then the ciliary body and the ciliary muscles are responsible for the actual shape of the lens. Now the lens is elastic in and of itself, and it has a shape that it wants to be in. However, the ciliary muscles can stretch the lens in every direction to adjust the shape a little bit. But we'll talk about in a little bit, like the amount of like wiggle room that the ciliary bodies have to play with the focusing of your eye is about 5 diopters. So that's really important. Refraction. This is also pretty much the only topic that we learned for the MCAT that is actually useful in medical school, besides like maybe the amino acids, right? So refraction, right? You're finally using something that you had to learn for the MCAT. And we're just going to toss away lenses. So because the eye is convex on both sides, right? It's biconvex. It flips everything that we see in both directions. It flips it horizontally and it flips it vertically. So everything is both inverted and reversed when it's projected onto the retina. So like everything else in neuro, it's completely backwards. And then the eye, obviously, your brain obviously accommodates for that based off of the way that the nerves are ran and distributed across the back of the retina, right? So, and this is the MCAT part, right? So just a quick terminology. The focal point is the actual physical spot that the image is projecting to on the back of the eye. The length is the distance from the middle of the lens to the retina, essentially. And then the plane is like perpendicular to not necessarily the lens, but to the axis of the lens. So for example, if this lens was like a little bit thicker here and it caused the axis to be shifted a little bit, the focal plane would actually be like up here. But when we talk about adjusting focal length when you're fixing near and short-sightedness or near and far-sightedness, what you're doing is you're moving this focal plane either closer to the lens or further away from the lens. And then when you have astigmatism, which we'll talk about, you have to correct this axis so that it lands basically in the dead center of the back of the eye again, so that you can get like a clear picture. Right, so converging lens. The converging lens is the convex lens. I literally remember that because the first 5 letters of the words are the same, right? So converging lenses bring the image towards itself, right? When the light leaves, brings light towards. And then diverging lens is the concave lens. I just remember that the converging lens is the convex one because they're spelled the same, and then the divergent lens is the other one. Diopters, you don't need to know this, but just for your information, 1 diopter equals the inverse of the focal length, basically. And that's the standard power of like measurement that they use. Convex lenses are considered to be positive, while concave lenses are considered to be negative diopters in power. And our eye sits at 65 diopters, right? So when you're looking at a prescription, right, one of your prescriptions, you'll notice that like we don't change too much with glasses. So people can have pretty bad vision and their eyes really aren't that far off of like physiological stats, right? The cornea has a power of 40 diopters, but like just across the board, right? It makes sense. It's shaped like a lens. And then the lens itself has a adjustable diopter between 20 and 25. And this is what I was talking about, where the ciliary muscles will pull the lens outwards and it flattens it out. And as you flatten the lens out, you refract light less. So the more the ciliary muscles pull the lens outwards, the more it, how can I say this? It pulls the image forward. So This is a much better slide for that, right? So this is how we end up with near and short-sightedness. So hyperopia, you can see things that are far away but not close, right? And the reason for this is because the image is falling behind the retina. So we fix that by adding a convex lens, and it pulls the image towards the retina. This is also why, so as you get older, right? As you get older, you lose elasticity of the eye, you lose strength of the ciliary muscles, and it actually kind of naturally will push the focal point back, right? And then you need to switch a lens you need to add a lens to correct this, right? So this is why most people who are myopic, like as you get older, it can actually fix the myopia a little bit, and then it starts to progress into hyperopia, right? Short-sightedness, you fix with a concave lens. You're gonna have a question on this. You're 100% gonna have a question on this. So just know that if you have hyperopia, you fix it with a convex lens, and if you have myopia, you fix it with a concave lens. But this is why, is because when you have what you're doing is you're changing the focal point, and you're making it so that the focal point is landing on the retina again. Yeah, so that's so it clears up your vision. And then, like I said, astigmatism. So this would be true if the eye was perfectly symmetrical in every direction. However, if you think about it, the lens, some people have lenses, I do, for example, where it's not really perfectly round, it's more like oblong. And what that actually does is it will change the amount that light is refracted in every plane, basically. Now that is a circle, so there's an infinite number of planes, but they've kind of found that if you just do it in 12 different directions, it's enough to fix vision. And then that's when they'll refer to that as like cylinder. You're not going to get tested on this, at least not while you're on that island. So the first kind of pathology is cataracts. Everybody's kind of familiar with cataracts, right? It's the clouding of the lens. Lens gets cloudy, you can't see out of it, right? I mean, that just makes perfect sense. The predisposing factors, the really two big ones are aging and diabetes, or is it diabetes? And the reason for this is obviously, as you get older, proteins just kind of like break down and accumulate, and then they start to build up in the lens. But with diabetes and the super high yield thing is that sorbitol starts to accumulate because your body has too much glucose and it shunts down the sorbitol pathway, and then your eye is lacking like the proper enzyme to get rid of sorbitol properly. So a lot of times you'll see they'll like just straight up ask you what the cause of the cataracts are, and the answer will be sorbitol. The other thing is you can get just accumulation of free oxygen like radicals, right? Because like this is full of water, right? And when UV light hits water, it creates hydroxyl radicals, which just kind of damage everything. So as it damages the proteins, cataracts can accumulate. The other thing too to keep a note is that any like infection you have can also cause cataracts. It's kind of like scarring, and you can think of it sort of like scarring like the lens. So the way you diagnose this officially, even though you can usually see it on people, you do a slit lamp examination. The other times you'll do slit lamp examinations are really for like, they can talk about them for any of the eye disorders. But Wilson's disease is the other thing that you're going to learn this semester, that like what this is basically you have too much copper in your body, and it causes like Parkinson's sort of, and you get these like Tyler Fisher rings in your eyes. But like they'll be talking about like these neurological symptoms, and then I'll ask you like what diagnostic test you should do, and the answer is a slit lamp examination. So just keep this in the back of your head. You'll be much more likely to be asked about this as a diagnostic tool for Wilson's disease than cataracts, but this is technically what they do. The biggest thing about cataracts is knowing sorbitol, that sorbitol causes it. Also, long-term use of glucocorticoids, long-term use of like oral steroids, like you can have iatrogenic cataracts. All right, so glaucoma. So the aqueous humor is what the actual fluid is called, and it is produced in the ciliary body, right? And then it flows out around the lens into the anterior chamber, and then it gets reabsorbed. Now, it can get reabsorbed in two places. I think Ulal did this with you guys, says that 35% of it, up to 35% of it gets reabsorbed uveosclerally. Amboss and UWorld, I think, both say 10%. And this is from the step book, so I think 10%. The point is that the overwhelming amount of the fluid gets reabsorbed in the trabeculae, right? So it goes to the trabecular meshwork, and then it gets reabsorbed in the canal of Schlemm. Okay, so what you need to know, really, is that your eye tends to maintain a pressure from 10 to 15 millimeters of mercury. Anything above this is considered glaucoma. Anything above 15 millimeters of mercury. For the purposes of the exam, right? There's a lot of technically here with the eye, but because nothing in the eye is really like super highly tested on as far as like the eye itself. It's really like the motor lesions that they test a lot on. So, but this glaucoma, right? So you need to know the pathway that this takes. You need to know that most of it's absorbed in the trabeculae. And you need to know that where the drugs, and we'll go over it in a second, act on these pathways, basically, right? So if you're going to develop glaucoma, there's two mechanisms you can develop glaucoma by. Either you can produce too much aqueous humor, or you can decrease your reabsorption of it, right? So we're going to obviously give drugs that either increase the reabsorption of it or decrease the production, right? So originally I had on here, so in his slides it says anything over 25. They're not super like tricky about it on tests. It will be high. It will tell you that it's high. I had on here previously that if you don't see an elevated intraocular pressure, the answer is not glaucoma. I don't care what the rest of the stem says. But I took that out because I don't want to like have that on there and you guys miss a question because of it. But I've never seen a question where the correct answer was glaucoma and the intraocular pressure wasn't elevated. And part of that is because they almost only ask you about acute angle glaucoma. They really don't ask you about primary open angle glaucoma, and I'll explain why in a second, right? So regardless, glaucoma, it's an increase in intraocular pressure, and it's anything over 25 is like, this is for sure glaucoma, and it can be much, much, much higher. I think I saw a thing that said it can be as high as 60 in these patients. And they're going to get tunnel vision, right? So they lose peripheral vision first, and you're going to see on a ophthalmic examination, you're going to see optic cupping. Optic cupping is your dead giveaway for glaucoma. If you see optic cupping in the stem, you can just answer glaucoma. And what that is, in case you don't know, is basically the light part in the middle of the optic nerve just gets big. You can see it's damage to the optic nerve, but that's what you're seeing is you're seeing that like this circle itself is increasing in size. Now with open angle glaucoma, that reabsorptive pathway, they call it the iridocorneal angle. I would know that is normal. It's not the aqueous can be reabsorbed normally through it. But regardless, your pressure is still raised, and this is usually due to like an increase in production, right? The big thing of this is you have no headache, you have no redness of eye, and the vision loss is progressive. It is not sudden. They will gradually lose vision slowly over a long period of time. So basically, instead of going blind in their peripheral vision, it'll become hazier and hazier, and then eventually they'll start to lose vision and it'll move inward still, right? Acute angle glaucoma, it's completely blocked. So you're not reabsorbing any of the aqueous. Well, I shouldn't say any, but you're really not reabsorbing the aqueous humor. It can't get to the trabeculae. It can't get to the UV resorptive angle. So you get a significant and sudden raise in intraocular tension. Patients will present with a headache and redness of eye. I've literally seen them show a picture of this before, and you see the eye and it looks kind of like conjunctivitis, and then you read the stem and you're like, oh, well, this doesn't really make sense. They're losing vision, right? If it looks like conjunctivitis, but they're losing like vision, it's probably acute angle glaucoma, right? It usually happens in both eyes, but it can only happen in one. But so that's like another giveaway too, right? If it's in both eyes. This is less common, but it's much, much, much more frequently tested than primary angle glaucoma. And part of the reason is because we can cause this one. And the reason we can cause this one is because of drugs, right? So I'm going to skip these for a second and come back. I want to go back to that, right? I think this is more important to talk about this first before we talk about the actual drugs, right? So acute angle glaucoma can be precipitated by mydriasis, right? So if you give someone an anticholinergic drug like atropine, right, you're going to basically anything that dilates the iris, dilates your pupil, the iris itself has to go somewhere. So it moves to the periphery and it can completely block off this angle, right? And close the trabecular network, right? So in your eyes, right, for a quick refresher, I don't know how high yield this is, but it's important to understand. You have two different types of fibers that are basically make up the pupil. You have the constrictors, which are concentric around the pupil, right? This is innervated by the parasympathetic nerve system, right? And these muscles are muscarinic 3, right? It's important to know this. I know it sucks, but these are the only receptors that they actually test us on, is like knowing whether they're muscarinic or adrenergic receptors, right? And then your sympathetic system, responsible for dilating the pupil, the dilator muscles are alpha 1, right? So that's these radiating fibers. And it makes sense, right? Because if you have a circle that you need to make bigger or smaller, you can have a muscle that shrinks and constricts in as a sphincter, but then relaxing it's only going to open up so much. You wouldn't be able to like open past a specific point, right? So we have radiating fibers that come out, and those are the dilator muscles, and those are sympathetically controlled, right? So giving someone a anticholinergic drug or a alpha 1 agonist can dilate the pupil, and then you can precipitate closed angle glaucoma. So like I was saying, there's 2 ways to basically treat glaucoma. You can either decrease the amount of fluid produced, or you can increase the amount of reuptake. So he has here, and these are not this is not Dr. Paul's side. I'll get back to Paul's side in a second. But Dr. Alal basically has, you can treat with prostaglandins, you can treat with beta blockers, you can treat with alpha 2 agonists, right? Not alpha 1. Or you can treat with topical carbonic anhydrase inhibitors. And then for the acute closed angle, the real answer for acute closed angle is you have to do surgery. But in the meantime, you throw everything at them. You literally hit them with every class of drugs. And by everyone, I mean everything except for prostaglandins. So to treat your, this is Dr. Paul's slide. As always, he's the GOAT. You hit him with an alpha 2 agonist, right? So any of the idines. You hit him with a beta blocker. It's usually timolol. The reason why you give timolol is because it comes in an eye drop. And then carbonic anhydrase inhibitors. Acetazolamide here, but acetazolamide is like systemic carbonic anhydrase inhibitor. And I don't know if I've ever gone on like a soapbox about this, but we don't give these. You don't give systemic carbonic anhydrase inhibitors anymore if you can avoid doing it, because they're really bad drugs for your body. So they use durzolamide as a topical. And in this case, topical really means it's more like an eye drop, right? And then you give pilocarpine, right? So if it's acute angle, you give all 4 of these. But more often than not, they will ask what precipitated it, like what the problem was, and the answer is like, oh, someone gave them atropine, right? And then for closed angle, or for open angle, you can treat with you start with the prostaglandins, I believe, and then I think you go to a beta blocker after that. But yeah, this is for this. No, this stupid increased eyelashes. I know that sounds really weird, but there's a lot of questions that like the question stem will say something about them like noticing their eyelashes getting thicker, and it will ask what drug they're on, and it's just prostaglandins. But it can also cause hyperpigmentation of the iris. Like you'll see little I don't know, they're like little brown spots that kind of accumulate. But yeah, that's pretty much all you need to know about the glaucoma treatment. This is, you will get 100% get questions on this, and that's why usually I don't harp on pharm too much, but like you are definitely going to get questions on this, and it's really only 5 classes of drugs, so those should just be free answers for you. Know that I don't know if I've said this specifically, but I like this slide because he separates it into drainage versus production. Know that prostaglandins and pilocarpine increase the drainage, right? Specifically, actually, no, you do need to know this. Prostaglandins, it increases. Prostaglandins just increase permeability generally, right? So you actually end up with more UV outflow, whereas pilocarpine specifically increases the trabecular outflow. So that's super important and high yield. Knowing those 2 things. But yeah, so back to prostaglandins. Like I said, yeah, you see he has them highlighted here even. And then increase eyelashes. That's like the weird, they like to treat on side effects, right? But this is the first choice for just regular old glaucoma. And then again, he has these listed as like chronic simple. The only difference is in acute you have to do surgery, but you hit him with the kitchen sink. And then beta blockers, of course, watch for asthma. Acetazolamide causes metabolic acidosis, renal stones. So we don't give carbonic anhydrase inhibitors usually. And if we do, you give them topically. This is probably I would bet in all of the NBME question bank, if there are 6 questions that the answer is carbonic anhydrase inhibitor, 5 of them is dorzolamide topically for acute angle glaucoma. I would never put I personally would never put a carbonic anhydrase inhibitor as an answer on a question outside of this specific instance, because it's just basically never the answer, unless they're talking about a nasty side effect, right? Because it is like it does cause a sulfa drug reaction, right? Or it causes metabolic acidosis. Yep. So back to the iatrogenic thing, right? Super high yield. Know this. Please know this. If you give them any of the ephrins, if you give them an alpha-1 agonist, you can precipitate this. If you give them atropine, you can precipitate this. Very high yield. The retina, I'm not big on embryology, but maybe it's worth remembering. The lens comes from the ectoderm. That makes sense. It's like it's like the front kind of, right? And then the retina and the optic nerve come from the neural tube. That should make sense because the retina and the optic nerve basically butt off from the brain, right? And the brain comes from the neural tube. Oh, also in the ophthalmoscope, in case any of you, I don't know, slept through your ICM, the macula, right, and the fovea, that's like the center, that's where you have your most of your vision is. And then your optic disc, right, is a little off to the side. I think it's like 15 degrees offset or something like that. This is where the optic nerve and like the vessels come out of, right? The structure of the retina, okay. Once again, this isn't super duper high yield for big exams, but for the block exam, if there is a question about it in the bank, they're probably going to use it. So be familiar with the whole thing, but you don't need to like get in the weeds, right? So the big thing about this is the way that the retina is set up is actually kind of backwards from how you think it would be. So all of the nerves, like the cell bodies, the neuron bodies, are actually like on the inside, like closer to the vitreous humor, right? And then the rods and cones are kind of like laying down on the pigmented epithelium. So which means that when light enters, it has to go in through the lens, in through the vitreous body, and then it has to pass through all of these cell bodies before it hits the rods and cones. And the pigmented epithelium, which is kind of weird, right? Like I thought that was kind of weird. But when it makes other things make sense, right? So this is the photosensitive layer, right? But it does a lot more because it's thick, right? So photosensitive layer needs constant support from the non-photosynthetic layer, basically, the photoinsensitive layer. And this is the layer that's you can basically think of them as like supporting cells, right? The big thing that they do though is this. I don't know if anybody remembers immune privilege from second semester, but this photoinsensitive layer, I would say its second most high yield function, aside from like number one, obviously being supplying nutrients to the photosensitive layer, is that it protects the inside of your eye from your immune system. The reason being is your immune system doesn't really know the inside of your eye exists. So if you get a penetrating injury that exposes the inside of the eye to the immune system, you will start to form autoantibodies against the inside of your eyes and you will go blind. So sometimes they'll talk about like a person gets like a penetrating eye injury, and then like what do you have to do to prevent future problems or complications? And it'll either be like, what is the future complication? You have to know that like they can get autoimmune attack, right? Because you lose immune privilege, or you give them steroids for a while to suppress the immune system so they don't develop antibodies against the inside of their eye until it heals. Because unfortunately, like let's say I get stabbed in my left eye and like it heals, and then I start to lose my left eye because my immune system's attacking it. Those antibodies will still be recognized in the right eye, and I'll lose basically both eyes from an autoimmune attack, right? So yeah, just know the way this is laid out. Just know that light comes in this way. Retinal detachment. So this is like another really big pathology, right? So when you get a stem where the patient's talking about losing their, and a lot of this, I'm gonna be honest with you, it's really hard to mix these up, right? Because when you have glaucoma, like the vision, it starts in yes, they both kind of start in the periphery and they come inward, but with glaucoma, it's like a circle, right? It's like concentric usually. Whereas with retinal detachment, it's usually from one side. And with glaucoma, like again, like I said, because they usually ask about acute angle, the patient's eye will be like painful and red, or they'll have a headache. Retinal detachments, never ever painful. You can cause a retinal detachment like secondary to something that is causing pain, but like the detachment themselves, that it does not cause any pain. And that's a pretty good way to weed on stems. The other thing too, elderly diabetes, right? All of the eye problems you're susceptible to pretty much by being old or a diabetic, right? Diabetes predisposes you to basically everything. But for the eye things, they like to harp on it a lot. But the thing that will really cue you in a stem is if they talk about floaters, flashes of light, or a dark curtain, but not and not to be confused with amaurosis fugax. Really, it's these two big ones. If either of these two onset suddenly, you have a retinal detachment, right? I've had floaters my entire life. My retinas are not detached. They have to be like sudden onset. They didn't have them before. Now they see them, or they see a lot of them, or they have flashes of light. Another interesting thing, why old people are more susceptible to this is kind of the same reason they're more susceptible to hematomas, right? So as the brain shrinks, it puts more pressure on the bridging veins, and then they can like tear, right? So actually, as you get older, the vitreous humor kind of dries up, and it starts to pull like on the inside of the eye, and then that can lead to an easier like retinal tear and detachment. You need to do surgery to fix this. So there's no drugs associated. If you want to reduce, if they ask you how to reduce the patient's risk for retinal detachment, the answer is probably treat their diabetes. Then the actual structure of the rods and cones, this is the only like physiology that like they have for this whole thing. This whole presentation is like that they did is pretty. They don't ask a lot of questions about this stuff, but it is really, really, really important to know this foveal pit and what the fovea is. So the fovea is basically where all of the cones are. It's 100% cones. And I actually really like this because it illustrates it a lot, right? So the periphery of your vision has rods, and I'll explain why that is in a second. And the central center of your vision has cones. Generally, rods detect motion. Cones detect acuity, right? Resolution. I think the optic disc is like a blind spot where the optic nerve comes in. You don't have any receptors here at all. But the reason the fovea is a big deal is because you don't have that layer of ganglion cells and bipolar cells, right? So the light can just directly get to the rods and cones, so it's less obstructed here, which helps with visual acuity. So cones versus rods, right? Cones are in the center of your view. Rods are in the periphery of your view in your retina, right? Cones have low convergence, and what that basically means is it's essentially, you can think of it as like one cone for one ganglion and one bipolar cell. Whereas rods have high convergence, which means you have a bunch of rods innervated by slightly less number of bipolar cells and then innervated by a single retinal ganglion. So this should make a lot of sense. This should make a lot of sense because when you think about the fact, you really need to internalize that cones are responsible for seeing things and rods are responsible for seeing motion, right? Because if your brain is trying to distinguish between motion, it only has to know, is there something there at all? Or is there not something there? So you can have a very wide part of your vision processed by basically a single neuron. Whereas when you're trying to your brain's trying to process the information from cones, you're trying to figure out the shape of something, the texture of something, the color of something. There's a whole bunch of things your brain's trying to process. So it makes more sense that for every cone, there needs to be a neuron, whereas for every 20 rods, there can be a neuron. Like, that's not the same number, but like it's just important to think, right? It's really important. You almost certainly have a question on the distinction between rods and cones, and also the M and P ganglion, which I'll talk about in a second. Cones use iodopsin. This is responsible for your color vision. Rods use rhodopsin, which is responsible for black and white vision. Also referred to as daytime and nighttime vision, photopic and scotopic vision. Photopic vision is during the daytime. When you have light, you see with photopic vision. I don't think that should be hard to internalize. And then scotopic vision is named after like the deactivated form of rhodopsin, right? But ganglion cells, right? So you have your peripheral cells and you have your central cells, right? So unfortunately for y'all, peripheral are not P ganglion cells. However, they're magna ganglion cells. Why are they magna ganglion cells? Because they're huge. Their dendritic fields are very large. Why are their dendritic fields very large? Because they cover rods. And as I just said, a lot of rods will be covered by one ganglion cell, whereas a very small number of cones, effectively one, will be covered by a single P cell, right? So I remember this as M for motion. M for motion. M ganglion cells detect motion. M for motion, right? You see motion in your peripheral vision. M for motion, right? And then your parvocellular ganglion cells. Oh, sorry. This is. I have to correct this. I'll correct this before I post it. I copied this over and it just didn't save this version. Anyways, so ignore this. Ignore these three lines. They're the opposite of this. So your P ganglion cells are in your central retina, and they're mostly cones, not rods. And then your they're responsible for their impulse is slower, and it makes sense because when you're using your peripheral ganglion cells, it's when you're like really looking at something, you're trying to read, you're trying to focus on it. Whereas your rods and your M ganglion cells, it's a really fast impulse because you need to be able to see something out of your peripheral vision much quicker than something that's right in front of you, right? This is an evolutionary thing. A person who responds to something moving in from their peripheral vision faster is more likely to not be eaten by a lion, right? And that's kind of like the big thing, right? So M for motion, it's like when out of the corner of your eye, you see something, you think it's a spider, you jump back, right? And then you look at it, and then you're thinking about what it is. Never mind, it's just a piece of drying lint, right? That is, you're using your P ganglion cells. This is really important. I'm harping on this because you will get a question on this guaranteed. You will get a question on this 110%, probably two. You're probably going to have one where you need to know where these are located, and then you're probably going to have one where they're going to ask whether or not you know either the impulse speed or the diameter of the receptive fields. So you'll probably have two questions on this slide. Macular degeneration. 90% of questions that you have about macular degeneration, they're just going to give you drusen nodules. But actually, macular degeneration is the number one cause of blindness. That's why we're tested on it. You lose your center of vision, right? So it results in scotomas. All scotomas are like little oddly shaped regions of vision loss that don't correspond with an entire field. So you know it's not like a nerve issue, right? Because if somebody comes in and they're like, I can't see vision, the left half of my face or the left half of my field of view, you know it's probably a lesion in a neural pathway. Whereas if somebody comes in and they're like, there's this black dot in the center of my vision, and when I look around, the black dot moves and it's always in the same spot in my field of view, then you know it's probably macular degeneration, right? So anyways, so dry macular degeneration, you need to know that you'll have drusen droplets. Also, unfortunately, listen, you can answer every single question without knowing these pictures. However, you can also answer every single question basically knowing these pictures. So I think it's worth learning what the ophthalmic exam photos look like, right? So drusen nodules, definitely know what these look like. You'll guaranteed you'll have a question on these, right? So dry macular degeneration is drusen droplets, and a lot of times what they'll do is they'll basically describe macular degeneration, and then they'll ask what you would see on like a fundoscopic exam, and the answer is just drusen deposits, right? Which is yeah. And then wet macular degeneration. So wet macular degeneration is due to new blood vessels, essentially. It's bleeding caused by the production of new blood vessels, neovascularization. A lot of times when they ask about this, what they want you to know is that it's treated with VEGF inhibitors, right? Vascular, either endo or I think it's endothelial growth factor. If you stop the growth of the blood vessels, you will stop the progression of the wet macular degeneration. Usually that's like a sneaky way they like to ask questions on this a lot. Rhodopsin. The rhodopsin is it's the protein that essentially, or receptor, photoreceptor, that allows us to see things, right? So rhodopsin is actually, believe it or not, it's the very first G-coupled protein receptor that we ever discovered, right? It is unbelievably widely studied. This is the first one. So remember the GPCR, right? So it crosses the membrane 7 times. It's made up of two things. It's made up of opsin protein, and it's made out of retinal, which is a form of vitamin A. The vitamin A part is the photosensitive part, right? It flips conformation, and when it flips from cis to so cis retinal will be hit by light. And again, don't confuse it with retinol. Retinol is the storage form. Retinal is like the vitamin A form that we use. But anyways, when when the cis version is hit by the sunlight, it gets converted to the trans version, and it then dissociates from rhodopsin, right? And it triggers the all the phosphodiesterase stuff is right. It's basically like works off of this system, right? And then your opsin protein determines the wavelength of light captured. I've seen them ask this as a question before. This is why you're colorblind. You're colorblind because of deficiencies in the opsin protein. Actually, specifically, I've seen questions asking what chromosome opsin is located on. And now I know that might seem like a really stupid detail, but if you think about it for 2 seconds, almost every colorblind person is a male because colorblindness is X-linked. Opsin is located on the X chromosome. I'm not promising that's going to be on your block exam, but I've seen that come up more than once in multiple test banks. But yeah, so anyways, these are constantly being eaten. I don't know by what, probably the sun. And they're constantly being reproduced, and they get produced here, and then they get moved outwards, right? These little optic disc things, or whatever they call them. But yeah, this is the actual meat and potatoes, right? So you have metarhodopsin 2, which is like a really broken down version of rhodopsin. This is what activates phosphodiesterase, which is responsible for this whole like light dark vision thing, right? And then you have scotopsin, which is just what they refer to unbound opsin as. So I've seen questions where like they're basically explaining this feedback loop or system, or however you want to refer to it, and they'll ask like in the cells what will be elevated, and the answer is scotopsin, because if you have a lot of transretinal, you're going to have a lot of scotopsin because it's unbound, right? But anyway, it's just a quick refresher. I say quick refresher. This is really complicated. Mostly these are the 2 things they're going to ask you about, but it is generally good to know that these cells sort of work backwards of how you think they do, which is when you have darkness. I guess it's easier to go with light. When you have light, you have metarhodopsin, right? And because you have metarhodopsin activates transducin, which activates phosphodiesterase, which inhibits cyclic GMP, which cancels out these channels, right? So now you no longer have calcium or sodium flowing into the cells, but you still have potassium leaving. So the cell becomes hyperpolarized. And that's that, right? The cell becomes hyperpolarized. That you should know. You should know this. You should know that light makes metarhodopsin, which makes transducin, which stimulates phosphodiesterase, which decreases cyclic GMP. Anytime you see something that talks about cyclic GMP, you really need to internalize it because very few things function through cyclic GMP. Basically, the only 2 times that a system has anything to do with cyclic GMP is if you're talking about nitrous oxide or Viagra. Which brings me to my next point. This is why phosphodiesterase inhibitors like Viagra cause blue vision. Is because when you take a phosphodiesterase inhibitor, you get more cyclic GMP, and it messes with this cycle. Right? But yeah, so no, in the light, these hyperpolarize. He put on his slide that it's weird because these cells like hyperpolarize and become like more active. It's really not that simple because it's really complicated. There's a lot of different layers of like bipolar, you have like the bipolar cells and the unipolar cells, right? Like the way that our body actually turns light into a signal that like looks at your brain is every cell in the eye, with the exception of the the MNP ganglions, they're not generating action potentials. Only the ganglions, the MNP ganglions, create action potentials. Your rods, your cones, all of the other cells are all like inhibitory cells. So really, these are working as inhibitory cells when you're exposed to light and dark. But again, I don't. Yes.
Hi, this is Destiny. So you mentioned that if you're on Viagra, you get blurry vision.
Blue vision, like blue.
Oh, blue. Got it. Thank you.
Yeah. And the reason is I spent way too long looking this up because I thought it was kind of weird, and I wanted to know if my initial guess was correct, and it sort of is. Blue's like the most aggressive wavelength of light, so it creates like the biggest impulse. So as you lower like the threshold, or you increase like the threshold required to like trigger a light response, basically only the like blue parts, like the cells in your eye that detect blue, are firing because you're lowering or you're hyperpolarizing the cells when you give or you're depolarizing the cells when you give Viagra. So it's making it harder for them to fire, to not fire. And then, like I said, these are actually inhibitory cells. Rods and cones are inhibitory cells. That's like the TLDR on this. Know this. I'm sorry if I confused anybody. I thought this was really interesting to learn. But just know this. Know the light turns rhodopsin into metarodopsin eventually. And then metarodopsin stimulates transducin, which then activates phosphodiesterase, which then inhibits cyclic GMP, which then prevents calcium and sodium from entering the cells, but potassium remains unaffected. I've also actually, since we're talking about stupid questions, I've also seen a question where they basically asked what happened to the potassium levels when you applied a phosphodiesterase inhibitor to these cells, and the answer is nothing. Well, not nothing, but like it continues to decrease, but nothing compared to physiological levels. And this is why they function as inhibitory cells. So these are the only cells, these ganglion cells, right? The MMP ganglion cells are the only cells that produce action potentials. Every other cell in this whole system is an inhibitory, modulatory, graded potential cell. And you have two kinds. You have on cells and you have off cells. They're named for whatever is in the center of their cells. And basically, if these cells receive signal, if the on cells receive signal from their dendritic field from the middle, it will be an on signal. And if they receive from the outside of their dendritic field, it'll be an off signal. The reason is they're arranged like this. This gives you a lot more visual acuity and like resolution, right? You can think of it as like adding pixels to a screen when trying to detect like nuanced changes in light, because basically every ganglion can regulate itself by saying like, okay, I have light here, and these cells are not firing. Therefore, I know that I'm receiving light. And kind of like the same thing here. Like I don't have light here. These cells are firing, right? If I don't have light here, but these cells are firing, then I know that I'm wrong, right? And that there actually is light, right? So the only thing you need to know about this is that there are both kinds of cells. They're the same neuron, same like family of neurons, but they have their own jobs. One of them only detects when light is on, and one only really detects when light is off. And that's how this is what creates like the actual action potential that gets sent down the retina. And for the on cells, they're slow firing and they increase in rate when they get stimulated. Whereas the off cells are fast firing and they decrease in rate when they're stimulated. And again, that should make sense because if you imagine you hit this whole area with light, right? For the on cell, I'm hitting this whole area with light, and most of the area is dark, right? Whereas with the off cell, I'm hitting most of this area is light. I don't. Oof! I should have thought about how to explain this to you guys before I did this. The off cells, when exposed to light, decrease the frequency of action potentials that they're sending to the brain. The on cells, when they're exposed to light, increase the frequency of action potentials that they're sending to the brain. I hope that doesn't confuse. But yeah, it's really important. It's really important to know that these exist also. And now for what I'm assuming is the real reason that everybody's here today, visual pathway lesions. So I draw this on every exam. And I know that seems like it's a lot, but I promise it's not. Because all you really need to know, right? So you have the eyes. You need to know, like I've said 1,000 times, everything in the brain is backwards, right? So you have your optic cup, draw the brain, right? So when light comes in the eye, right? So this is like your field of view, and this is the eye. It's coming across. And it's coming from left to right, right to left. It's coming from up to down. It's coming from down to up, right? And it's hitting, like I said earlier, it's getting inverted and reversed. So your brain needs to translate that to things being the right way up. So it sends all of the fibers, well, not all the fibers. So it sends fibers in a bunch of different directions, in as many directions as possible. It wants you basically, this whole system has a lot of redundancy built into it, so that you don't go blind. In nature, it's harder to go blind because you have all this redundancy, right? So I recommend being able to draw this out, but we'll walk through this. All right, so from the medial portion of the retina, the nerve fibers cross in the optic chiasm. From the lateral portion of the retina, I should use a different color. Can I do that? I should fix this. Okay, so from the medial portion of the retina, it crosses immediately at the optic chiasm. From the lateral portion of the retina, it doesn't cross. It kind of sticks to it. It keeps to itself, right? It just doops. So what that means is that the medial portion of your vision is carried laterally in the brain, right? In like relativity to these, right? The medial portion of your vision does not cross. The lateral portion of your vision does cross. I guess they refer to that as temporal as nasal, right? Yeah, in like naming convention. So that means, oops, that if I lose the right, like my right temporal field of vision, that the problem is either here or here, right? If I lose the right side of the vision, because it's backwards. Then once these get to the lateral geniculate nucleus, right? Lateral is for vision, medial is for sound. They continue through either the parietal lobe or the temporal lobe. And again, like everything else, it's backwards. So the bottom of your vision, the inferior portion of your vision, goes through the parietal lobe. It goes up. The superior portion of your vision goes through the temporal lobe. It goes down. Right. So some people refer to this as Meyer's loop, pie in the sky versus pie on the floor. And by pie, they just mean like the quarter, right? Because you get like these little wedge-shaped kind of chunks taken. So if you look here, obviously normal vision, you have the whole field of view, right? If you lose complete vision in one of your eyes, that's called anopia, right? How am I going to do that? I'm going to cut out the optic nerve, right? That makes sense. Okay. What happens if I hate how they do it like this. What happens if there's something wrong with the optic chiasm, right? What happens if, let's say, you have a tumor pushing on the optic chiasm, right? Well, you're going to get bitemporal hemianopia. And what that means is you can't see anything in the field of view in your periphery. And why is that? Well, that's because your peripheral view is coming in and it's being projected onto the nasal sides of your eye, which are then being carried by those more medial fibers, which do cross, right, in the optic chiasm. So if you have a tumor that's pushing just a little bit, but not too much, instead of going completely blind, you'll just be pushing on this optic chiasm, right? And then you won't be able to see things in your peripheral vision, right? Bitemporal hemianopia, also known as heteronymous hemianopia. Why is it heteronymous? Because on your left eye, it's the left side of your vision. And on your right eye, it's the right side of your vision, right? Conversely, homonymous hemianopia, right? That means homo, same, hetero, different. Same side of the field of view for both eyes, right? So now let's walk this back. And how does this make sense, right? If I lose the left side of my field of vision in both of my eyes, I am losing the nasal portion of my left eye, and I'm losing the nasal portion of my right eye. And now that's kind of weird, right? Because like nasal portion on my right eye is responsible for the left side of my field of view, and the nasal portion on my right eye and my nasal portion on my left eye is responsible for the left side of my field of view, right? So that means that the optic tract has to be damaged, right? Because these cross and these come and scoot out to the LGN, right? So the important thing is if you lose half of a field of view, the lesion has to be before the lateral geniculate nucleus. It has to be above it. If you lose only a quarter, then the lesion has to be after the lateral geniculate nucleus, and you know it's in one of the loops, right? So you can just section those off in your brain. Then you can just then, like I had just said on the previous slide, the inferior portion of your view travels through the loop of Meyers, or the superior portion of you travels inferiorly through the loop of Meyers, right? And then the inferior portion of your view travels superiorly back to the visual cortex. I really recommend you be able to draw this out. Being able to draw this in black and white, I promise helps just as much as being able to draw it like in color. And it doesn't take very long to draw. I would literally just do this. And then like you'll remember the rest, I promise. Because this is where I feel like a lot of people get confused, is this part right here. Yeah, no problem. Okay, so if you have hemianopia, any kind of hemianopia, the lesion has to be before the lateral geniculate nucleus. Because after, I guess in it technically, but that'd be a really weird question for them to ask. Because the only time that those tracks are running next to each other in any direction, the only time that like you have two halves of your field of view running next to each other is essentially at this cross here in the optic chiasm or in the optic tract. So if they show you a picture, because sometimes when they ask you questions, they will literally give you these as answer choices, or they'll give you a field of view and ask you what's wrong, right? If you see half is black, you know it has to be either the optic chiasm or the optic tract. If you see a wedge, then you know it has to be in one of the two loops. And know that it's, once again, backwards, right? So bottom left field of view is gone. Well, that's top right. Top left field of view is gone. Well, that's bottom right. Does that make sense? I hope this makes sense. He put this here, binasal hemianopia. The only way this is possible is if you have bilateral carotid artery aneurysms, internal carotid artery aneurysms. That's gotta be impossible. But in theory, if you lose the middle of your vision, it's you're pressing on the outside of the optic chiasm, right, from both sides, which is only possible if you have an inferior carotid artery aneurysm in both inferior carotid arteries. The other thing too, you remember the ICA, right? It can push on the third cranial nerve, so it can cause like ptosis. So if you see somebody, or if you see a question stem that talks about, because it doesn't have to be both, right? It's usually just one when you're talking about carotid artery impingement right here. If they have hemianopsia and also like ptosis, it is 100% an internal carotid artery aneurysm. And that's a problem. That is an immediate problem. So if it's in a question stem, it's an internal carotid artery aneurysm. If you see it in the clinic, go get some. Tell an attending. But yeah, this is not. When you look at this, it's complicated. But when you actually draw it for yourself and just think to yourself, everything is backwards. I promise. I promise it's not bad. Right? If you can get to here, you can figure out any questions they ask you on these, right? Because like, yeah, sure, you have to remember that the loops, right? And you have to remember which one goes to the parietal lobe and which one goes to the temporal lobe, and you have to remember that the loop of Meyers is like the bottom, right? The loop of Meyers pie in the sky, right? But just they're all backwards. They're all backwards. It's all backwards. I can't say it enough times. If you can draw this, just know the X is in the middle, and you have like the little greater than or equal to signs on the outside. You are pretty much good for this. Because then, like, even if you forgot, you would know, like, okay, well, if I cut here, obviously I have nothing coming from this eye. And if I cut here, I lose this half of the eye. Right? Well, this half of the eye, which is like this half of the field of view because it comes in from the other direction, right? I am such a big proponent of on your neuro exams, draw out as many of these things as you can, even if you know it. Listen, I did 1,000 of these. I know this forwards and backwards and up and down and left and right. I would still not answer a question without drawing this. It is too easy to confuse yourself. And then this is just, I put this in here because I thought this was good for people who like to have like more like memorization or like to like see it written out in words. And I just threw this on here so that you kind of had them side by side for like a comparison. The other thing that I didn't mention is if you have macular sparing, right? So you have hemianopsia with macular sparing. That's a special case. And basically what that means is that you have a PCA infarction. And the reason why a PCA infarction causes that is because it's called macular sparing. So if you see hemianopsia with macular sparing, you automatically know that it's a PCA lesion. And the reason is because the MCA and the PCA anastomose, and you get a dual blood supply from both sides. And the region that the supplies or the region of the brain that processes information from the macula is very large, which should make sense to you because the macula is where most of the cones are, which is responsible for most of your like actual visual processing, right? So it takes a lot of brain power to distinguish one thing from another, whereas it doesn't take a whole lot of brain power to determine whether or not there's something moving in your peripheral vision, right? That's a very binary thing. There either is something moving or there isn't. Whereas what is moving takes a lot more processing power, right? So if you see macula, if you hear macular sparing, you know it is 100% a PCA lesion. And I did this. I drew this myself. But you can't really read the words, which is why I didn't want to use this. I recommend doing this for yourself too, like just drawing one. Drawing it out really will help internalize for yourself these different pathways, right? And knowing that, please God, the Myers loop goes to the temporal lobe. The not Myers loop. I don't know if this has a name. Goes through the parietal lobe. And I'll be honest, the only reason I remember this is really convoluted. Myers loop is pie in the sky. Pie in the sky has to be the inferior part of the brain because it's backwards, right? So however you remember this, but I just drew this. In his slides, he has a blank one of these. I highly recommend just throwing it on your iPad and drawing it out for yourself. It'll help you remember it a lot. All right, so then I talked about amaurosis fugax. So this is transient blindness. Sometimes patients will describe it as like a curtain coming across their vision. This is not to be confused with retinal detachment. They will not have flashing lights. They will not have floaters. The reason is this is just a transient blood loss for whatever reason. So either it's usually a sign of some type of occlusion to the retinal vasculature. So maybe they're throwing emboli, right? Maybe they have AFib and they're throwing emboli, and you want to catch that before it becomes like a real problem, like a stroke. Or they have carotid ischemia, right? Maybe their carotids are becoming clogged, right? Carotid sclerosis, stenosis, which is causing transient drops in blood supply to the eye, which is causing the retina to essentially die. But like I said, because it usually resolves, well, I shouldn't say usually resolves, but because it quite often resolves, it's usually transient. It's transient blindness. It can also be caused by temporal arteritis. If you remember back to temporal arteritis, immediately give them steroids so they don't actually go blind. And then very rarely, this is migraines, not on a test. I do not believe that you will get this with a test. Because like it even says here is like you have different visual aberrations that they're going to test you on a migraines, not amaurosis for you guys. The other big thing is this is true. So because this is transient vision loss and like one field of view, if you were to lose, like, let's say my left eye, I lose my medial field of view on my left eye, I'm not going to know as like a person unless you make me cover my right eye. So this is the other reason that when you're doing like neuro exams, it's really important, and physicals, it's really important to actually make the patient cover their eye. If you talk to any attending, you'll be amazed in the amount of like visual problems and sort of pseudo blindness that old people will have and just not think to mention. So this is that's why you make them cover their eye. Ocular motility is a stupidly high yield. Absolutely need to know this. Cranial nerve 6 is the abducens nerve. It abduces the eye. The muscle that's in charge of that is the lateral rectus muscle. Cranial nerve 4 is your trochlear nerve. It innervates the superior oblique muscle. Why is it called the trochlear nerve? Because the tendon that holds the superior oblique muscle is called the trochlea. I don't know why they did that, but and then cranial nerve 3 is literally everything else. Cranial nerve 3 is basically the whole eye, but except for the lateral rectus and the superior oblique. So this is down and out. This is, I have up and in. It's not really quite up and in, and I'll talk about that in a second when we get to like trochlear palsies. But like they're just the opposite of each other. Maybe don't internalize this one, but I say that to myself every time because it pulls this way, right? Like the trochlea is like in your nose, basically, right? So it does pull the eye in this direction. But because these muscles, it's an oblique, it more or less rotates the eye. That's not quite strictly true. And it doesn't have like the same opposition. So it doesn't really cause the down and out that the third nerve palsy actually does. But it's just, you need to know this. You absolutely need to know these. You need to know all 3 of these. Please God, know the 3 of those. Aside from that, it makes it really easy. Because they're not going to ask you like really minute questions like the inferior rectus or the inferior oblique. They're only ever going to ask you if you only need to know that like the abducens nerve is responsible for the lateral rectus muscle, because sometimes they'll talk about like a 6 nerve palsy, or they'll talk about MLF syndrome or something, which we'll talk about in a second. And the answer will be like which muscle is innervated by the nerve that's affected, and it's lateral rectus or superior oblique. Usually not superior oblique. They usually don't ask. Very rarely do they ask about trochlear nerve palsy, and if they do, it'll be in one specific case, which I'll talk about. Cranial nerve 3 palsy is huge. The other thing that's to know, the way the nerve is actually like structured itself, motor output is the center of the nerve. Parasympathetic output is the periphery of the nerve. So what that means is, let's say I have diabetes, right? And one of the ways that diabetes causes problems in your body is it glycosylates your blood vessels, right? So like it hardens them, and that you become really poor at like delivering nutrients to your body. Well, it affects the nerves, and the way that it affects the nerves is because you have decreased diffusion of oxygen and nutrients, basically because you have reduced blood supply because you're diabetic. It's harder for the oxygen and the nutrients to penetrate down to the middle of the nerve, like bundle, which means that motor function is what's affected in vascular disease. So if you have like ischemia or something, or really bad diabetic over time, that's when you're getting at like your ptosis and your down and out gaze, right? Because like if you can usually this person's not going to like lose all of cranial nerve 3. Like there could just be like a little ischemia, right? Like just a lowered blood supply for whatever reason. Maybe even just like because they keep becoming hypotensive for whatever reason. It's going to affect the motor function of the eye. Whereas if somebody has compression on the nerve, it's going to compress this parasympathetic part first. So then you're going to get like your pupillary signs, right? You'll have like the blown out pupil. Or an uncle herniation. I would know those. Know the difference between that. I've seen more questions on this than I wish to have seen. This seems like a detail that shouldn't matter. I've seen a lot of questions on this, like from the perspective of not thinking I would see any. The other thing to know, which I don't really have in here, and I don't really know how to include it, but it got brought back up to me recently, and I was like, oh yeah, that's right, I knew that, but I forgot. Giving newborns oxygen. Bear with me for a second. So I talked earlier about how macular degeneration, wet macular degeneration, if you give them VEGF inhibitors, it helps because part of the problem with macular degeneration is it prevents the neovascularization for the inside of the eye. I know this doesn't specifically have to do with what we're talking about right now, but I promise this is something that is like, you didn't think you need to know it, but I've seen it in more than one test bank. So if you have a premature baby and you give them oxygen, it decreases global production of VEGF in their bodies, which means that their eye is never properly vascularized because your eye continues to vascularize late in development. So if you're born premature, it has to do it after you're born. And if you're being given oxygen, it decreases expression of VEGF because you have more oxygen throughout your body. So your body thinks you need less blood supply. And then it can cause blindness in kids. I don't know where to throw that in, but it just got brought up. I was like, oh, I should tell that to people at tutoring. So just so you know, that's a for your information.
This is Jonathan.
Yes.
What's like the cranial nerves that are affected with the locked-in syndrome?
We'll get to that. And by that, I mean, it's right here. Okay, so it's the pons. Locked-in syndrome is the pons, right? Osmotic demyelination syndrome usually. I don't really. So I wish I had a side view of the pons, but maybe I can. Nobody make fun of my drawing. So if you imagine, it's kind of like this, right? The pons, more or less. With locked-in syndrome, you get damage here. We'll say that this is the pons, right? You damage here. Which destroys the horizontal gaze centers, which are cranial nerves 6 and 3. Your abducens and your oh my goodness. Was it the ocular nerve? Oh my goodness. Optic nerve? No, it's not the optic nerve. I don't know. Cranial nerve 3. I'm sorry. But anyways, it destroys your centers here. But your reticular formation, which is in the back and is responsible for like consciousness, that is where your vertical gaze center is. It's actually a little higher up. It's like basically, so locked-in syndrome is here. Does that make sense? It's ventral. It's the ventral part of the midbrain. I don't know who is.
Did you say the ventral part of the? So the ventral part of the midbrain is affected, but there's pons on the slide.
Or the pons. I'm sorry. The pons. I said midbrain. I meant brainstem. It's the ventral part of the pons. This is in the pons. Osmotic demyelination syndrome happens in the pons. Your sixth nerve nucleus is down here with your. It's the whole point of the slide, right? So your sixth nerve nucleus is down here, and your pontine reticular formation is right here, and then your third nuclei is up here, right? So what happens is when the pons gets damaged, you lose the sixth nucleus and the PPRF. So this whole system falls apart. So you don't get any horizontal gaze, and the reason that happens is because of the actual pathway that your body sends signals. So when you get an impulse to send from your brain, right? So let's say that I send my cortex, sends the signal to move my eyes to the left. What actually happens is, and this is talking about seizures, but it helps. So it immediately crosses over, and my left frontal, like the left part of my brain, is telling my eyes to move. This isn't what I want. This is what I want. This is what I want, right? So and we switch sides. So the right part of the brain is telling the eyes that it's stimulating the PPRF, which is going to stimulate my left cranial nerve nuclei, right? My left abducens nuclei. And if you remember, cranial nerves are always on the same side as the lesion. And the reason for that is because these are the lower motor neurons. The cranial nerves are the lower motor neurons. So my right frontal eye field tells my left sixth nerve nucleus that it needs to move my left eye to the left, right? It's going to stimulate the lateral rectus muscle, the abducens nerve. The left abducens nerve abducts the left eye. And it was told to do that by the right side of my brain, the right frontal lobe, right? Or the right motor cortex. As it does that, it's going to send a signal contralaterally to the third nucleus. And the third nucleus, my right third nucleus, because it is the lower motor neuron, it is a cranial nerve, therefore it is on the same side, projects to my medial rectus in my right eye, which pushes my eye to the left. So an interesting thing to think about is when I tell my brain I want to move my eyes to the left, what I'm actually doing is telling my left eye to move to the left, and then my left eye is basically saying to the right eye, oh, hey man, we're going this way. So this is how you get palsies in the this is what causes the palsies and the MLF syndrome, which we'll come back to that. But yeah, and I'll revisit in a second. But he likes to talk about this. I guess I've seen questions. This is important because it's contralateral. It's like the same deal. That he talks about the whole right eye, wrong way eyes. So basically, it makes sense. If you have a seizure here, it's going to push your eyes to the right. Seizures push the eyes away from the seizure. Maybe a good way you can remember that is flashing lights cause seizures. If you see like blinding light, you're going to look away from it, right? So stimulating the left cortex causes the eyes to move to the right. And the reason is, like I just explained, because the signal comes across and it stimulates the right abducens nucleus, which is going to abduct the right eye. And it's the right abducens nucleus through the medial longitudinal fasciculus is going to tell the left ocular, that's what it is, the oculomotor nucleus, to adduct the left eye, and then your eyes end up looking to the right. Now, if you knock out the lesion, that's kind of the opposite, right? You're not going to get a signal. The eye is not going to abduce because the right abducens is dead. It's not telling the left oculomotor nerve to adduct the left eye. Therefore, you're going to get unopposed motor function of the opposite muscles, right? And you're going to look to the correct way eyes, right? So he says right and wrong. But that's confusing, right? You're going to look to the left. If you have a lesion on the left, you look to the left. If you have a seizure on the left, you look to the right. You look away from the blinding light, you look towards the problem. Hopefully I didn't confuse anybody in this. I know that was kind of probably convoluted for a minute there, but back to this. This is the
Can you
important thing.
explain that again? What?
Yeah, which part? The whole thing?
Yeah, the last part.
Okay, so I'm gonna explain how this works again, and then I'm gonna. So if I want to look to the right, all right. If I want to look to the left, right, because it's easy. If I want to look to the left, everything in the body is opposite in the brain. So the right side of my brain is going to tell my left abducens nerve, right? Because cranial nerves are always on the same side. Because cranial nerves are lower motor neurons, right? So if you go back to brainstem injuries, you can always localize the brainstem injury by looking at the cranial nerves because they're always on the same side, right? So the right motor cortex projects the left PPRF. And you can just think of that because the PPRF and the abducens nuclei are like literally on top of each other. It's projecting to the left abducens nucleus. You know it's on the left because it abducts the eye, and my brain is telling my eye I want to move to the left. Therefore, it has to be the left abducens, right? Then, as it's the abducens nuclei is sending the signal to the lateral rectus muscle to contract to abduct my left eye, it's telling the oculomotor nucleus, hey, bro, by the way, we're looking that way, right? The brain doesn't connect, the motor cortex doesn't directly talk to the oculomotor nucleus. The abducens nucleus talks to it via the MLF, the medial longitudinal fasciculus. And the way that you can remember that this crosses, again, right, essentially crosses back, is because the third nerve nucleus, as all cranial nerves are, is a lower motor, well, that have motor innervation is a motor neuron, a lower motor neuron. It's the terminal lower motor neuron, which means it has to be on the same side. And it tells the medial rectus muscle to contract, therefore adducting this eye, adducting, right? And it makes it look to the left. So the brain tells sixth nerve, hey man, look to the left. The sixth nerve says to the third, hey man, we're looking to the left. And then if everything is okay, you look to the left. Now, because of that, because again, like I said, it's backwards, it projects across. If you have a seizure, you're going to have improper stimulation of this area. So what that's going to do is it's going to improperly tell your right, because now we're on the left side, right? The problem's on the left. It's going to tell the right abducens nucleus to contract. So the right abducens nucleus is going to just tell the left oculomotor nucleus, hey bro, we're looking to the right. Lateral rectus muscle on the right contracts, right eye looks to the right. Medial rectus on the left eye contracts, left eye looks to the right. So he refers to it as wrong way eyes. Because you're having a seizure and your eyes are looking away from the seizure. So I always remember this because flashing light causes seizures. And the eyes are going to look away from the bright light. Now, you just flip it, right? There is now no input. So there cannot be a signal that tells the eyes to look to the right. Therefore, you will have unopposed activity of the opposing muscles. So the eyes are going to look towards the lesion. So the thing that I said that might have confused was he says right way eyes here, but that's confusing because he used the left as an example, right? So it makes it sound like the eyes are turning to the right. But what's happening is when you have a stroke or something, the eyes are going to turn towards the lesion. So again, the way I remember it is you look away from the bright light, you look towards the problem. All right, so now MLF syndrome. So what happens if you knock this out, right? The MLF. So if you knock out either the MLF or cranial nerve 3, shout out to Ben Rush, the other eye can't adduct. So what happens is you stimulate the PPRF, your right brain tells your left PPRF that you want to look to the left, and the abducens nucleus sends the signal to your left eye, and your lateral rectus contracts, and your left eye goes left. But the oculomotor, the cranial nerve 3 nucleus, never gets the memo. So it doesn't adduct. So it stays looking straight ahead. So then what happens is you get a nystagmus. Because this eye is looking straight ahead, and this eye is looking off to the side, and now your eyes are no longer looking in the correct direction. So your left eye tries to correct, and you get a rightward nystagmus, right? Because we're always the direction of the nystagmus is always named after the saccade, right? The quick motion. Does this make sense? So another way to say that is if you have a right or a rightward nystagmus, you have a right medial longitudinal fasciculus problem, right MLF problem. Because your left eye will be correcting back towards the right. That is the saccade. And this is named after the nystagmus and named after the saccade. Is he typing? Yes and no. It can, but if you remember cranial nerve 3 palsy, if you completely knock it out, you're going to lose all those muscles, so you'll have down and out presentation if you lose all of cranial nerve 3, right? But there is a world where you could have some type of like really subtle cranial nerve 3 palsy, which would present the same as this, right? Because you would lose the ability to adduct the eye, and you would basically end up with the same thing. But you would also, but then, you know, you have to think about other things, like, are you going to have like a blown pupil? Are you going to have ptosis, like the eyelid drooping, right? Because it also innervates like that eyelid muscle. You're going to have unopposed trochlear muscle action, so it's going to pull the eye down and out. Yeah, so if there is, it has to be somewhere in the nucleus, which will essentially be the same thing as MLF. But they'll always ask about this in the context of MLF syndrome. You are 99% correct. It's the left eye will correct because the right eye won't move at all. You have a rightward nystagmus because the right MLF is damaged. Therefore, the right eye will not adduct. The left eye will abduct, but because the left eye is now looking off to the left and the right eye is looking straight ahead, the left eye will correct back to middle, and you'll have a rightward nystagmus. I just realized that my camera might be flipped for you guys, so this might be confusing, but I hope the words are making that sense, right? So again, if you damage the right MLF, what happens is you send a signal to the left abducens nucleus, which causes your left eye to abduct. But then because the MLF is destroyed, the cranial nerve 3 nucleus never gets the memo. It does not tell your lateral rectus to contract. It does not tell your right eye to adduct. The right eye is looking straight ahead. The left eye is looking off to the side. Now the left eye is ticking back, ticking back, ticking back. This is wildly high. You will have questions on this, guaranteed. I guarantee you'll have questions on this. I think I had 2 questions on this on step, actually. Questionably a third, but I might have gotten it wrong. So, but yeah, we can run through these. But again, if you look to the left, normally both eyes go, right? If you look to the left and you have a right cranial nerve lesion, you don't know. If you look to the right, now you know, right? Because your left eye is looking in and your right eye is looking ahead. If you have a right 6th nucleus lesion, you look to the left. That's okay, because your left 6th nucleus tells your eye to abduct, and it tells your 3rd nucleus to tell your right eye to adduct. In your A-OK, you don't know. But then when you look to the right, nothing happens because your 6th nucleus on the right doesn't do anything. So your right eye doesn't know to abduct, but it also doesn't tell your 3rd nucleus that your left eye needs to do anything either. So your eyes just don't know. So if you have a right 6th nucleus lesion, your eyes will not move to the right at all. If you have a right PPRF lesion, it's the same deal, right? Because the brain tells the PPRF to tell the 6 nucleus to move, but they're basically the same area. And then if you have, once you add the lesions, right? Now you get a nystagmus. So if you have a left MLF lesion, the left eye will not adduct. Therefore, the right. I wish he drew this. This eye will look to the right, and then it will saccade back to the left, right? I really wish he drew that, doing that, because it's weird, right? That it looks like it's looking straight ahead, but it's not. It's looking to the right, saccading back to the left because the left MLF lesion. Are we good on this? Someone give me a thumbs up. No, it's okay. This is probably the second most complicated thing in this whole semester because it requires you to know so many other things. All right, cool. All right, so then vertical gaze. Oh, wait. It's a leftward nystagmus. So your right eye will have a left nystagmus, a leftward nystagmus, because it's named after the saccade. Your left eye, or your right eye, would have a leftward nystagmus because it's named after the saccade. So that's why I was trying to say, like, the real way to draw this would actually be with the saccade to the left. The nystagmus is always named after the direction of the correction. Number 5 is a left. Your left MLF is destroyed, and your left 6th nerve nucleus is destroyed. No, it'll still be a nystagmus to the left. Wait, what did you say? Is that what you said? Oh yeah, yes, correct. Sorry. Yeah, the only difference here is because your left 6th nerve nuclei is destroyed, right? You're not getting any signals to tell your eyes to look to the left. Yeah, sorry. So that'd be quite the big like lesion, right? Like you're knocking out a lot of stuff here, right? You're probably gonna lose the PPRF. You know, this really should say left PPRF because it's above it, so it's more likely to hit. You're more likely to hit the MLF if you hit the PPRF, but I don't know. Yep, cool. All right, and the vertical gaze. So the same reason that vertical gaze is spared in locked-in syndrome, right? Osmotic demyelination, Pontine syndrome, is the same reason that you lose vertical gaze if you have a problem with it's almost always pineal gland, right? It's almost always a pineal, but basically, it's located higher, right? And it's towards the back, right? Because it's in the, do I have it on the thing on it? I don't. Okay, cool. It's located higher and in the back. So when you have a tumor of the pineal gland or a tumor below the pineal gland, it can press on this area. What usually happens is you have a pinealoma that blocks the cerebral aqueduct, which then leads to obstructive hydrocephalus, which then pushes on this. So you'll get increased ocular pressure and also this kind of vertical gaze palsy. They call it the sunset sign. Basically, you look down. That's it. This is not nearly as high. This is infinitely high more yield than this is. The only thing you need to know about this is if they describe it to you, you have to know that it's probably caused by a pinealoma. And so because of that, it usually happens in kids, right? And then they get the sunset sign, they look down. If they're asking you about like something adjacent to that, so like here, like they're looking down, right? So in order to compensate, they're like tilting their heads back. If they ask you something about that in adult, they're talking about trochlear nerve palsy. So if you get a question sent, it's like an adult is having like difficulty walking down steps and they're like tilting their head to one side when they come into your office. It's because their trochlear nerve's knocked out, and the only way to accommodate, so they're like tilting their head to accommodate. So like basically that eye will now be looking straight forward, and then they're just moving their other eye to like compensate for it. So the the trochlear nerve like comes out the back of your head and it goes like a really far away, right? It has like the longest distance to go of all the cranial nerves, so it's the most less susceptible to damage. It innervates the superior oblique muscle, as we talked about, which like rotates the eye and like kind of pulls it. So when you lose that, now you have it stretches this way, right? So now you have unopposed action of all of the muscles innervated by the third and sixth cranial nerves. So the eye rotates and like kind of points up, right? So you will tilt your head in the opposite direction to fix the diplopia. Really, the only thing you need to know here is that this is the trochlear nerve, right? Causes this weird thing. This is like a buzzword for STEMs about this, and then knowing that they tilt their head to the opposite side. I've never seen a question that asked about this that didn't ask like basically which direction they were going to tilt their head to, like which direction would correct it. And that is actually all I have for today. Because I don't want to do that. I just straight up didn't have time to find good questions for you guys without just like pulling them from the slides. And I figured I could just talk about all the lesions during the lesion things. But if you guys want to like run through either the visual tracts again or MLF syndrome again or something, I have no problem going back and doing that. I will find questions, like I'll try to find decent questions for Thursday's thing. But my sister's like about to have a Chiari malformation correction. So I've been going absolutely crazy trying to fix everything around the house for my mom before that happens. So also for med micro for this, it's really easy and simple and straightforward. I'll make like just a quick summary slide also to throw in on Thursday. But really know that like the most common cause of viral conjunctivitis is adenovirus. Know that like if they're talking about a kid with conjunctivitis in a question stem, not a kid, but like a teenager in a question stem, it's probably Neisseria. I think the big thing there is they want you to treat with fluoroquinolones. Virals you treat with ganciclovir, I'm pretty sure. But wow, like I said, I'll make a summary slide for all that. The med micro and like the actual like eye infections is like Finkel's gonna ask you her questions on them, and then that's it. Is there anything anybody wants me to run through one last time? No? All right. Well, then I will see you all Thursday.